Hi, everybody. My name is Arash Kia. I'm a Director of Clinical Data Science in Mount Sinai Health System. Today, I'm going to actually give you an overview how we incorporate the NLP actually pipelines and tools into our real-time clinical decision support platform. So hopefully by the end of this actually talk, you will be familiar with the actually rationale behind our optimization using NLP and also overall. Also, you can actually get an idea that how we actually use the NLP pipelines and tools. What is the architecture of our actually NLP pipeline, and how we stitch the components that we need to in order to generate the predictive scores coming from the NLP classifiers, or even the actually non-predictive kind of actually outputs. Also, we want to actually, I want to highlight some of the lessons that we learned and also challenges during this development and deployment process. Let's start from the actually from Mount Sinai Health System. Yeah, the clinical data science team is a small team inside of the Mount Sinai Health System. We have 8 hospitals located throughout New York City and Long Island. We are actually one of the largest actually health systems in US. Over 4.1 million annual patient visits, above 400 ambulatory practices, more than 40,000 actually employees, and we have actually more than 3.5 outpatient visits, which gives us real actually value in terms of doing many different type of machine learning kind of experiments by using this huge data. And also, it's all the hospitals are academic hospitals and affiliated with the Icahn School of Medicine. Our team is actually is a very multidisciplinary team with different background, computational science background, clinical science background, clinical practitioners, and engineers, specifically DevOps engineers. Okay, what we do? That's the first question. So our team actually focus is decision support cycle. So this cycle, when we say the decision support cycle, we actually we are talking about 3 main components. One, data, the other one is knowledge, the other one is learning. So usually everything starts with the documentation, which is actually the motor of generating data in a bedside. And usually at the bedside, data retrieval happens. People try to actually say that, see that what is the actually different lab exams or lab tests, or even the different clinical evaluation for the patient. They from actually yesterday or from previous visits, they aggregate that data. They actually see the trend. They come up with actually some differential diagnosis, say that the patient is actually developing sepsis, the patient is developing acute kidney failure, and there are tons of different actually rounding is happening, which is actually equal to the knowledge dissemination. And during this continuous feedbacking and continuous refinement, the whole concept of quality of care actually usually is constructed at the bedside. Yeah. What actually we found as an optimization opportunity is actually that clinical decision process, which is a process to linking the clinical knowledge to the patient information. And definitely the goal is actually to improve patient health and healthcare delivery. What we try to do is using different kind of actually capacity in the data science to make that clinical decision system as much as possible data-driven. We could actually easily do the real-time patient data retrieval from the different EHR platforms. We are doing actually real-time computation to generate the information inside. And also, we actually established a real-time communication with clinicians and frontline providers to deliver that information inside. And on top of everything, we established a continuous learning program by actually doing the retraining and ingestion of the feedback from the users and so on. Here is the actually general overview of our clinical data science platform. As you can see here, there are some platforms in which you can find in most of the hospitals and health systems. The ADT is related to the admission, discharge, transition platform. Usually administrative staff, they actually use that. Epic is a main EMR, electronic medical record, which all the clinicians and frontline providers, they put their actually evaluation and documentation there. There's a lab platform. And also there are other different type of platforms like wearables, which or EMS platform, or waveform platform, or platform related to the radiology and imaging. Sorry. So all of these actually platforms, most of them actually, they generate the HL7 messages, which is big XML actually files. And we have a chance that through the active integration gateway, we can actually get or we can actually do the real-time data interfacing with this AIG active integration gateway and get all the feed of the related ADT, all the clinical evaluation through the flow sheets, everything related to notes, labs, data from the wearables. Also, we can actually exchange that data through our actual interface, which is MetConnect, which is very simple HL7 parser. We put everything, convert all these XMLs into the JSON, and we try to do as less as possible transformation and normalization there to actually create something we call a data lake. And then from there, our streaming Spark data services trying to actually do the create a single view at different levels, at patient levels, lab levels, flow sheet level, and so on. And it will be saved in our transactional database and also a historical database. Our ML applications using the transactional databases and to generate prediction, score, notification, alerts for different actually users. We can communicate with them through the comment center or through the smartphone application like Haiku, or through the even the pager, the smart pager, which we use in Sinai, is Voicera. Here is the actually very simple flowchart related to how we create that, identify the updates, feed, and also create that single view. And you can see here that the main components are the NoSQL database, MongoDB, Kafka, and also Spark streaming, and everything is coming through our actually interface to this Mongo, and using the change stream and Kafka and our Spark streaming pipeline, we do the up insert into the documents and create that single view at the different levels. Here is the actual product development lifecycle is happening in our team. So as you can see here, so everything starts from the defining the optimization opportunity, which is usually is coming from the leadership or frontline providers, and we try to see if we can find any solution in the market or not, and if if there is solution in the market, how we can actually optimize that. Is it only limited to the structured data? Can we add the unstructured data, or can we add the imaging? Can we add the high frequency data and then optimize that solution or not? And then create a prototype, do the actually implementation, and then try to operationalize and actually using the updating pipeline to somehow have the opportunity of the continuous learning. This is let's go to the actually first use case, which is psychiatry use case, and this use case is related to the automated BROSET pipeline. What is this actually project about? The main focus of this project is aggression. And as you know, aggression is one of the most common concerns in psychiatry actually units. Because of the aggression, patients are subjected to more restrictive intervention. And so it creates stress and increasing stress and tension on both patients and providers. Currently, in the aggression management tools, most of them are actually, majority of them are subjective. So they need clinicians to do the evaluation at the bedside. And these subjective tools are actually, they don't have prognostic value. So the other problem is low sensitivity. So our goal, the prime ultimate goal, is actually building a classifier to identify the patients with high risk of aggression in our psychiatry and non-psychiatric actually point of cares. But at the first phase, without that, maybe there's actually opportunity here to automate this actually BROSET checklist that you can see here. It has 6 items and it's 0, 1, 0, 1 at the end. Actually, it gives you the score. The maximum is 6, and whatever is equal or greater than 2 would be considered as an aggression positive or high risk actually aggression patient. So without that, we can actually create an automated pipeline to look at the last 12 hours clinical documentation, clinical notes, and try to actually reconstruct this 0, 1 kind of items and generate the expected aggression scores. For doing that, we actually we had a good opportunity. So we had 3 years data of evaluation, the BROSET evaluation happening in our psych actually point of cares. We actually created a cohort to include all the visits and all which they had at least one BROSET evaluation, completed BROSET evaluation. And then, each BROSET has a score, actual score, and also the timestamp. And at the time of that BROSET actually timestamp, we try to actually look back 12 hours and put together, create a corpus of actually progress note and care note, and then use our develop an NLP pipeline and to generate that BROSET score, and then check the error rate and also identify that we can, is there any actually possibility to optimize that or not. Here is the computational actually flow of our BROSET, automated BROSET. As you can see here, we can get all the progress note and care note and social worker notes from the EPIC. Do the sampling. It means that at the time that we want to generate the expected BROSET, we look back 12 hours and put together, collect all of these notes and different type of notes and create one corpus text, and then pass it to our document assembler, and then sentence detector, tokenizer, normalizer. And then we decided to actually use two approaches. One is the Spark NLP actually steps for the bag of words. It means that using the stop words cleaner, lematizer, stemmer, and ngram generator, which we are using from the JSL packages. And then actually by using a map, the output will be actually matched with our 6-item actually array, and then generate the expected BROSET score based on the 0101 actually for each item. At the same time, also we tried to use the output of the normalizer into the using by BERT embedding, and then using the JSL NER, and using the map to actually map the NER chunk to the those 6 items and generate the expected BROSET score. And here is the actually result that we actually found by comparing with NER with the bag of words approach. So as you can see here, NER shows higher percent of the actually same score as actual, 74% versus 68. So the underscoring for both of them are actually is around between 7% and 8%, no significant difference. But it seems that the bag of words, in bag of words approach, we have the over scoring more than 24% versus the 18%. And here is showing the distribution of difference from actual score in actually these two bag of words approach and NER approach. And you can see here that again the overscoring is actually more prominent in the bag of words approach. But then we had this discussion with actually in our working group, which including all these actually potential users and also the leadership of psychiatry actually department. And since actually the actual positive rate that we found in our cohort was 4%, and bag of words was actually generating closer positive rate somehow, 3%. Yeah, we decided to actually deploy the bag of words approach, and for the first actually phase. And here is the trend of our BROSET violence checklist completed from 2018 until January 2021. As you can see here, during the COVID, actually, it was almost actually zero, but after actually July 2020, so you can see that now we have something around 7,000 to 8,000 BROSET evaluation every actually month in Sinai Hospital. And we also actually were looking at the trend of the BROSET completion by hour of day to see that at what time we can actually our actually engine should be running. And we came up with actually 5 a.m. in the morning and 5 p.m. actually at the afternoon. So, and you can see that there are 3 different peaks, one around the 9 a.m., 10 a.m., and the other one at 12 a.m. and also 8 p.m. These are the peak of the BROSET evaluation in our hospital. And here is the next step that we actually want to do for this project. We started from May 2021. We built the data curation pipeline, then NLP processing pipeline. And now we have both of actually those pipelines, NER and bag of words. We came up with that, actually creating that map to map the output of each pipeline into the itemized BROSET score, and then try to actually set up some charts review by using the psychiatrist to see that if there is actually actual clinical documentation that we can use for the BROSET items, or no, there is no that kind of documentation, and so in that case we cannot actually optimize our pipeline based on the current documentation level in Mount Sinai Hospital. So we in late June we actually started our working group, and we in the middle of actually deployment and integration with the EMR, and also hopefully we can start the active pilots very soon in November 2021, first in the psych point of care, and then hopefully, if everything goes very well, in the non-psych setting. The next actually use case is oncology use case, and it's related to the clinical documentation improvement alert system for metastatic disease. So here our main actually focus is metastatic disease. Yeah, we want to identify the inpatient encounters with high risk of metastatic disease. Why? Because if we can actually optimize our capture rate, there's a big chance for us to actually improve our health system rank in the US News, and that brings really good value for us. What are the challenges here? The challenges is actually currently all the CDI actually reviewers, they should review all the clinical notes, which is actually, it's very high volume, and the cost of processing also is very high. Yeah? And the other thing is this metastatic disease is there's a high class imbalance there. So if without using classifiers, actually I think we will have very low expected productivity, which we're seeing now. What we want to do is we want to actually develop a classifier to predict risk of metastatic disease as soon as the patient actually get discharged from the hospital. Here is our proposed solution. When the patient gets discharged, there will be a trigger that our actually NLP processing pipeline will be actually triggered to collect all the pathology reports, radiology reports, and progress note, care note, which we call it clinical notes from the EMR, pass it to the text classifier that we actually want to build, and then the classification output will be based on the medical record number, visit ID, and metastatic score, and top 3 note IDs, which can send it to our coding system, and hopefully it can actually generates ICD-10 based on those actually identified notes. The first step was actually building a historical cohort actually for this project. The data was radiology reports, pathology reports, progress note submitted by resident, fellow, and attending, and care note by registered nurse. So the data source that we used was Epic and Cerner as actually ADT, admit, discharge, and transfer kind of feed, and MSHS as actually our financial and coding actually kind of database. What we did is we actually created a label, data, and actually logic to label each inpatient encounter as a metastatic positive or metastatic negative. Metastatic positive, actually, that labeling logic works with DRG and APR DRG and ICD-10 codes to identify new metastases in each actually encounter. If we find, we say that this is metastatic. If actually find a new one, then again, it's a metastatic. But if it's carrying over actually the old metastatic into the next encounters, we don't actually call it metastatic. And the other side is everything is non-metastatic, and we actually label these two type of actually visits. And then what we did is we actually we took 200 visits randomly, and then asked oncologists to review that to identify that these are actually metastatic or not. Sensitivity was 98%, or specificity actually was around 90%. And then when we reviewed, we found that actually all of those coding labels are right, and we could convince also in the second round and oncologists that these patients are not false positive and they're real metastatic patients. And then actually here is our computational flow. Again, from the EPIC, we actually collect our pathology, radiology report, and progress notes, apply specific actually sampling logic. Means all the progress notes from the admit date to the discharge date for radiology report and pathology report from the actually last or previous discharge date to the current discharge date. Create one corpus of text for pathology, one radiology, one progress note, and pass it to the document assembler, sentence detector, tokenizer, normalizer, and then using the BERT embedding and NER pre-trained NER model from for each one we are using the different kind of NER model, pre-trained model from the JSL, and then we filter on the specific entity type, diagnosis, and sign and symptom, imaging finding, and pathology formations. We have a specific actually feature engineering approach, vectorize them, and then split into the train set, test set, 70% trained, 30% test, and then actually training over the training set so in the training set also do the actually undersampling because of the class imbalance, and we use 10-fold cross-validation training by using random forest and build our final metastatic classifier. For the feature selection, actually, what we do is we build classifier based on each actually different type of the modality, text modality that we actually use. Yeah, radiology report, doing the sampling, using the NER, actually filter on imaging findings, and then we built actually classifier by using the random forest, and then doing the RFE and get the actually final selected features, which be the array of the radiology features. And same thing for pathology and clinical notes. And then we actually assembled all the arrays, and we did the training. And here is actually our model performance. In the training, after undersampling, because the training was done actually over around 10,000 visits with the positive rate of, because we did the undersampling 50-50. So the AUC that you see is in our training set after cross-validation was actually 98. In the test set, we actually validated that actually that classifier's performance, and gave us the AUC 0.84. Our PR precision recall area under curve, the training cross-validated training 98, and then when the positive rate goes down, it goes to the 0.4. And here is our proposed threshold, which is 0.49, gives us 80% sensitivity and around 71% specificity. So we also actually took a look at the feature importance, and as you can see here, most of the actually features are coming from either radiology or care note, progress note, and it's actually a combination of the imaging findings and also the signs and symptoms. And another actually nice thing that we found about this feature importance is so the most important one is less than 6%, and the distribution of the prediction power among these top 30 actually features, most important features that you see is actually distributed very smoothly. And for the next step, we are actually deploying this pipeline, and also by using all of the objects that we built in the batch, and try to actually start the silent pilot. And hopefully by October, we start the active pilot to see what will be the actually performance when we are using it on the prospective data sets. Thank you so much.